Assalamu alaikum wa rahmatullah. We will be starting just to catch up with the time because we have a lot of heavy agenda. Bismillah ar-Rahman ar-Rahim. Wa salatu wa salamu ala nabiyyina Muhammad wa ala alihi wa sahbihi ajma'in. This topic, peripheral ulcerative keratitis, is one of the most important topics to be presented and elaborated. It's a very common entity that is being faced in the clinic, on the emergency room. And it's frequently missed in terms of the way of working up patients, in terms of choosing the proper line of treatment and ultimately reaching to the diagnosis. And for you to understand this entity, we have to understand the distinct morphology and immunology of the corneal limbus, or the periphery of the cornea. Because unlike the central avascular cornea, or paracentral cornea as well, the periphery of the cornea has a distinct feature that makes it more vulnerable to inflammation and infection and immune-related condition. And when you look at this simplified segmentation of the cornea, you will see that the limbus and the periphery, the transitional zone, are those areas which has access to a blood supply, peripheral blood supply, unlike the central part of the cornea, which is a non-vascular part of the cornea. Now, any trigger whatsoever is that trigger, be it an inflammation, an infection, a trauma, a malignancy, a local or systemic immune reaction, is going to cause either complement activation, immune complex deposition, that is going to recruit more neutrophils and macrophage, some element of T helper 1 and T helper 2 dysregulation and upregulation was involved in certain diseases. This will result in release of some elements like proteases and collagenases, increase the vascular permeability. This in turn will increase the intensity of inflammatory cell recruitment to that area. More proteinases and collagenases. Cytokines will induce the production of a matrix metalloproteinase released from the keratocyte, which will add further insult to the injury and will cause an ongoing inflammation and melting that is going to be manifested clinically. Now, the limbus and the peripheral cornea obtain part of their nutrient supply from the anterior conjunctival and deep episcleral blood vessels, unlike the central part of the cornea. And the vessel extends to 0.5 millimeter into the clear cornea. And this can explain why you sometimes see a clear zone between the limbus and between the area of degradation and inflammation. Now, there is also subconjunctival lymphatics that drain into the regional lymph nodes. You can see it very prominent because these areas are hyperpigmented. These are the palisades of Vogt. You can see the channels in between. These drains into the regional lymph nodes, and it provides the access to the afferent arm of the corneal immunological reaction. Now, understanding the pathophysiology will help you to understand how disease occur and what treatment to choose and what is the outcome of that disease and why certain diseases don't respond to treatment and others do respond to treatment. Now, PUK is not a diagnosis. PUK is not anything more than a clinical description of what you see under the slit lamp. It is a peripheral, and it has an ulcer, and it's involved inflammatory cells. So it's a peripheral ulcerative keratitis. So it is a working theme that you need to have a systematic approach to it that has a priorities and has something that you should and things that you should not do. So by definition, it's just juxtalimbal corneal stromal inflammation that has three main components, which is an epithelial defect with stromal infiltrate and stromal degradation later on. And now the ulceration may progress either centrally or circumferentially. It has a variable severity depending on the cause. Now, when you enlist the differential diagnosis of a PUK, it's a huge list of more than 65 differential diagnoses. You cannot for sure memorize all of them, but you should practice a safe clinical approach in these cases. So it's either a systemic cause or it's an an ocular cause or a local cause. And either of them, it's either an infectious or a non-infectious. This is the most important distinction that you should make clinically. Now, some entities were mislabeled as a PUK, where they don't meet the criteria of being a peripheral ulcerative keratitis, like Tyrion's marginal degeneration, for example, pellucid marginal degeneration. These are a non-inflammatory corneal thinning and involve no ulceration. Now, the presentation is variable, as we mentioned. It typically presents as a crescentric shape of ulcer that is present within 2 millimeters of the limbus. The epithelium is absent or disrupted overlying the ulcer because epithelium needs an intact, smooth, and quiet stroma to grow over. Now, the underlying stroma is thinned later in the disease. There is a variable amount of stromal infiltrate within inflammation involving a contiguous conjunctiva and sclera. And it has been found that scleritis has been diagnosed in 6% of cases of PUK. And now this is a very important statement because the presence or absence of scleritis will shorten your list of differential diagnoses. Variable presentation. PUK can present with no involvement of sclera at all. It's a pure corneal disease. Or it could be, or the ulcer could begin at the junction of the cornea and the sclera as well, together. The corneal ulceration is close to the central corneal area in rheumatoid arthritis patient. So patients with rheumatoid arthritis, they have tendency to have a central spread of their melting and inflammation. PUK involving the peripheral cornea and the sclera is very prominent in Wagner granulomatosis. Wagner, they tend to have more scleral involvement. Now, when you come to evaluate patients with PUK, you have to measure the size, the site, the depth, the degree of inflammation, the associated features, the presence of absence of scleritis, and the presence of absence of superinfection as well. In your notes, when you first assess patient with PUK. Now, the clinical finding in PUK sometimes is linked to a certain diseases. For example, patient with relapsing polychondritis, Wagner granulomatosis, they have a clinical systemic finding, like saddle node deformity. Patient with relapsing polychondritis, they have very profound auricular chondritis. Wagner granulomatosis, they do have nasal mucosal ulcers, recurrent history of sinusitis, chest infection as well. Other systemic diseases are associated with peculiar systemic features. Now, as an ophthalmologist, you are the most responsible physician. It's not your responsibility to do a systemic checkup for that patient, but it's your duty to recognize patients who are eligible to be examined by other disciplines. You have to refer this patient. If an autoimmune disease just cross your mind as a cause of a PUK, then refer this patient to your colleague in medicine or rheumatology. You might help this patient to catch a lethal disease, and you can give him a good prognosis and decrease the mortality rate. Now, we have a huge list of lab tests for PUK. Now, doing this list of investigation for every patient is actually inconvenient for the patient, for the hospital, and for the investigation-wise. You have to be very smart in selecting this test. Now, for every peripheral ulcerative keratitis, you have to do scraping, whether you have infection or you don't. Scraping will help to debulk the inflammatory cells, to remove the infecting agent if there is, to facilitate the penetration of medication if you use a medication, and also it will help you to take these samples for a culture. Now, as we mentioned, it should be a multidisciplinary approach, especially in severe cases involving the sclera. Don't take it lightly because patient might die in 6 months if a diagnosis is delayed. And never over-investigate. Now, Mooren ulcer is a very specific entity. It's extremely rare. A few cases had been reported worldwide. But we need to know that from my experience when I was a resident and when I'm teaching resident and students, they have a very low threshold of diagnosing Mooren's ulcer. Mooren's ulcer is a diagnosis of exclusion. You don't go for Mooren's ulcer unless you make sure that all other diagnoses has been excluded. If you have a negative workup in a patient with specific ulceration pattern, in the absence of scleritis in most cases, with an intractable pain that is inconsistent with the clinical presentation, these are clues helping you to go with a diagnosis of or suspicion of Mooren's ulcer. We have no single test that tells you that this is Mooren ulcer or this is not Mooren's ulcer. Now, there has been a few classifications of Mooren's ulcer. It's not the scope of this presentation to give you a detail of management of each PUK entity. No, it's just an overview of how to handle those patients. But I found it very important to know the classification. And by the way, when you look at a classification of any disease, it is meant to tell you how to treat, when to treat, and what is the prognosis. If that classification does not serve this aim, then that classification is useless. So there has been changing pattern of classifying this Mooren's ulcer over time to target this issue. So this is the old classification of having into type 1 and type 2, the young and the old patients with a more severe, with mild to moderate and aggressive form, responsive to treatment and poor response to treatment. This is a very crude way of classification, but it's still being used and it has some usefulness. Now, the new classification that was postulated by Watson was the unilateral Mooren's ulcer that happens in elderly patient. It's painful, progressive ulceration, and there is an ischemia and non-perfusion of the superficial vascular plexus of the anterior segment, compared to the bilateral aggressive form of Mooren's ulcer that happens in the young age group, that progresses circumferentially, then centrally, and can end up in a complete opacification of the cornea. And by the way, Mooren's ulcer, they don't usually penetrate the decimate membrane. The reason of having an open globe or rupture of the decimate membrane in Mooren's ulcer is because of trauma, because minimum rubbing of the eye or touch of the eye can cause a perforation of the globe. Now, therapeutic guidelines, you should always know what are your therapeutic options before going to any pathology. Now, the available options are supportive measures. Is that all patients have to have their eye shield, especially those with a deep ulceration, and those who are vulnerable to have trauma like young, active children. Protective glasses is one measure. Bandage contact lens. A topical treatment like lubricants, especially preservative-free lubricants and antibiotics. You always try to utilize a preservative-free medication. You'd like to not to irritate the already irritated and inflamed ocular surface. And also the use of cyclosporin had been postulated. The anticollagenase agent, we will come to this, and the topical steroids. These are your weapons to use, but not all cases of PUK are amenable for this kind of treatment. Some of them, these measures are contraindicated. Now, topical steroids may be harmful in vasculitic PUK as they inhibit collagen production. This is true statement when you talk about prolonged use of steroid. Steroid in the early days will arrest inflammation, but when it exceeds 10 days, 2 weeks, now the collagenases or the inhibition of collagen production will start. Now, the anticollagenases, this is an important word about it. They are an adjunct therapy and not solo treatment, because there will be no patient who will need any of these medications alone. If he needed any of these medications, then the disease is not under control. You have to have it with a systemic medication or appropriate medical therapy. Now, the available is the topical Provera that inhibits collagenase synthesis, 20% N-acetylcysteine, which is a competitive inhibitor of collagenase enzyme, a topical vitamin C. Systemic medication is tetracycline, which is an old medication that should be used with caution with very old and very young patients. Doxycycline, 20 milligram tab once daily, was found to slow the progression. Now, the trend in practice is using 100 milligram of doxycycline BID. Now, this is the anti-infective dose of doxycycline. And it's relatively high. It's 10 times the dose of a 20 milligram. So you don't need the anti-infective dose. You need the anticollagenase dose of doxycycline that has been obtained by 20 milligram once daily. It's, by the way, commercially available in the market. Oral vitamin C had been postulated to also help in collagen synthesis because it's an important part in the formation of collagen. Now, topical cyclosporin with lamellar keratoplasty was noted to improve a healing rate in Mooren's ulcer in a Chinese study. Otherwise, the topical cyclosporin, topical tacrolimus was not found very effective in cases of PUKs. Now, systemic immunomodulator agents like antimetabolite, like methotrexate or cyclophosphamide, cyclosporin, and azathioprine are indicated if you have a PUK associated with a potentially lethal systemic vasculitis, like polyarthritis nodosa, relapsing polychondritis, systemic lupus, and others, or PUK that is associated with necrotizing scleritis. And presence of necrotizing scleritis is a poor prognostic sign for the patient. And when you have a patient with bilateral or progressive Mooren's ulcer, or a PUK unresponsive to aggressive conventional medical and surgical therapy. Now, combining steroids and immunosuppressant is a very well recognized regimen of treatment. But you need to know that you will push the patient you might push the patient into a profound immunosuppression. So if you are the one who started this medication, it is your sole responsibility to follow this patient or refer him to the discipline needed. It may take 4 to 6 weeks for immunomodulatory agent to reach the peak effect and not to start the effect. Effect will start probably in 2 weeks, but the peak effect might take up to 6 weeks, 1.5 months or 2 months to happen. Now, oral prednisolone is used temporarily to stabilize the inflammation until the immunomodulatory agent takes effect. Now, your goal of treatment, you should arrest inflammation. That's the first to do. Prevent superimposed infection if it does exist. And then enhance the healing. These are the stage of management that you should keep in your mind and design your treatment based on it. If the initial combination of therapy is ineffective after several months, the patient will be switched to a different agent. And by knowing that we have different mechanisms of developing peripheral ulceration in the cornea, you will understand why certain immunosuppressant will be effective in certain entities of PUK and not the others. Now, Wagner granulomatosis and polyarthritis nodosa are particularly responsive to cyclophosphamide, 2 milligram per kg per day when combined with systemic steroids. The cyclophosphamide is the drug of choice for almost all PUK with connective tissue disorders. And it's also a life-saving medication. Yes, it has a nasty side effects, especially on the urinary tract and immune system, but it's very effective in halting the progression of a systemic disease. Now, there are some special considerations when you give a patient an immunosuppression medication. Now, patient on cyclophosphamide should have a CBC checked every 2 weeks. Prophylaxis against pneumocystic cardiac pneumonia is also critical, particularly when combination of steroids and other immunosuppressive agent is used. Trimethoprim sulfamethoxazole, 1 single strength tablet daily, is given to those patients. I do advise that if you are working on a secondary or tertiary care hospital, to refer to your colleague on the internal medicine to take over. Steroid-induced bone loss must be considered, monitored, and treated, especially for vulnerable patients, like a female exceeding the age of 50. Now, biological agents are the new model of treatment. The problem with the biological agents are the cost, to start with. If the cost is not a concern, then the side effect is with these medications is another concern, but they are very effective in certain cases of PUK. For example, rheumatoid arthritis-associated scleritis and PUK, infliximab has been found to be very effective in managing these cases. The effect is usually seen in 2 weeks after initiation of treatment. Etanercept is less effective than infliximab. Rituximab, it is used in refractory PUK associated with Wagner granulomatosis. Now, we should keep in mind that heart failure, hepatotoxicity, reactivation of a TB, especially in an endemic area like the Middle East, and opportunistic infection, development of malignancy has to be put into consideration. Now, the surgical treatment is a choice when you have an impending perforation. The reason is to preserve the globe integrity. Surgical resection of the conjunctiva had been postulated, and the theory behind this is that when you resect the conjunctiva, you just cut the source of these inflammatory cells. This is true temporarily, but the problem is that the conjunctiva will keep growing every time. Now, a combination of surgical option depends on the size of perforation. You could just use a bandage contact lens if you have just a decimatocele, or use a fibrin glue. Cyanoacrylate glue has been used for perforation less than 3 millimeter. Cyanoacrylate has been found to prevent the influx of the WBCs from the tear film to the stroma. AMT is very effective in halting the inflammation. It has biological properties. It is a biological bandage contact lens. It is a magnet to the inflammatory cells, and it removes it from the field of the inflammation. Tarzolaphy also is a choice if you would like to increase the lubrication of the ocular surface. Tectonic surgery is the last resort of choice. We always try to avoid surgery because surgery per se is a trauma. And trauma can induce further degradation and inflammation to that area. So corneal patch graft, either lamellar patch graft or crescentric patch graft, corneoscleral or hemicorneal patch graft. Now, you should know that if you go for PKB, the failure rate is extremely high. It's 20 to 40% graft survival at 6 months only. Now, this is a patient who had a known case of rheumatoid arthritis, developed a peripheral corneal ulceration with vascularization of the peripheral cornea, and these large caliber vessels tells you that this inflammation didn't happen today. He probably had it on a recurrent basis. And an IV methylprednisolone was started. Inflammation was arrested in 12 hours because of the high dose of the medication, and in 3 days there was a complete healing. Now, this is an otherwise healthy 15-year-old girl reported progressively worsening pain and redness in her left eye during the previous 2 months. The diagnosis of scleritis with peripheral ulceration in the left eye was made on the basis of characteristic examination and finding of this deep violaceous episcleral injection. There is also a dilated perilimbal vessels, as you can see, with limbal edema, and a corneal epithelial defect. There is associated area with corneal thinning. Lab testing have shown a serum C-reactive protein level of 17.5, which is relatively elevated, and ESR of 115. Testing for anti-neutrophilic cytoplasmic antibody with cytoplasmic fluorescence was positive. A review of systems uncovered 2 recent episodes of otitis media in this young girl that were unresponsive to antibiotic. She had also an unintended weight loss. She had low-grade fever, fatigue, recurrent epistaxis, non-productive cough, shortness of breath, all of which had begun during the previous month. The urine microscopy revealed a granular and red cell cast. CT of the chest showed a numerous nodular parenchymal lesion that is consistent with the diagnosis of Wagner granulomatosis. Now, patient was initiated on oral steroids in addition to cyclophosphamide, and there was no ocular specific treatment was initiated. Over the next several months, she started to have a good healing, and she was kept on immunosuppressive therapy. Now, a PUK accompanied by necrotizing scleritis almost always indicates the presence of a potentially lethal systemic disease. Don't take it lightly. And this is a PUK with adjacent necrotizing scleritis in a patient who was previously diagnosed with a Wagner granulomatosis. Now, this is a slit lamp appearance of a PUK with scleritis. That's a pre-treatment picture, and this is a post-treatment picture with a cyclophosphamide. Now, this is a case of rheumatoid arthritis-associated PUK. A cyanoacrylate glue with a bandage contact lens was applied, and the patient ended having an intact ocular surface, healed stroma, and arrested inflammation. Now, viral PUK is an important entity because viruses are great mimickers. Now, HSV and Varicella zoster can cause PUK in the absence of dermatological finding. And you can, the mechanism behind it is a limbal-induced vasculitis. So when they have a vasculitis, they have an ischemia to the limbus, and then degradation and melting and inflammation. You would find a negative culture when you go for corneal scraping. A biopsy, if you have a good biopsy, then you would get a limbal conjunctival vessels by immunoprobing. A topical steroid and systemic antiviral agent is normally effective in these cases. This is a case of perforated PUK. It was, you can see a crescentric shape of inflammation, and a crescentric patch graft was done to this patient who was Mooren's ulcer. Steroids and immunosuppressant was ongoing. If you elect to go for BKB or grafts, you have to quieten the inflammation with immunosuppressant prior to the surgery, because the ocular inflammation, the degree of ocular inflammation will dictate the destiny of your graft. Now, as we mentioned, that PUK could be the initial sign of a lethal systemic disease. This is one study that have looked at the mortality rate in rheumatoid arthritis in patients developing necrotizing scleritis. In conclusion, limbal deposition of circulating immune complexes lead to vascular occlusion, subsequent leakage of inflammatory cells along with collagenases and proteases. The mainstay of treatment is to prevent ocular tissue, to preserve ocular tissue and prevent perforation and control the underlying systemic vasculitis. Initiation of appropriate immunosuppressive therapy with steroids and cytotoxic agents are life-saving. Biological agents have been introduced, and they gain popularity in the management of PUK. Thank you very much. Any question? It depends on the size of perforation. It depends on the condition of the ocular surface. If that perforation happens because of continuous melting, because of autoimmune, active autoimmune process, then you have to control it with either topical or systemic medication. You can apply a glue and bandage contact lens. If that perforation is large or is associated with, you cannot control it, then a surgical option, either lamellar or concentric or even full thickness graft, is warranted in these cases. But we don't usually go for surgery right away, because surgery is not going to end the problem. Surgery is the beginning of a new line of management, because you have to put an eye on that graft. That graft has higher potential to get melted, infected, and degraded more than the other part of the host cornea.
Ulcerative keratitis that is of viral entity if the patient has no active ulcer or previous episodes of viral disease?
That is true. You sometimes don't have any clue, ocular clue, of having a ocular or even dermatological clue of having viral. Things that will raise your suspicion is the presence of scleritis, the presence also of negative culture, negative systemic workup, ongoing inflammation despite having a appropriate medication applied. If you use steroids, topical steroids, on a viral PUK without coverage of antiviral, you will have a propagation of this infection and quickening of the melting process. Yeah, yeah.
Thank you very much for a very comprehensive review of PUK. This question is an important question, and I have seen several cases where they were diagnosed as Moorens and given immunosuppressive therapy, and they were due to herpes virus. I think herpetic infection may cause, but the single most important finding is the photophobia and pain. The presence of pain does not occur in herpes. And if you have a PUK without pain, you have to think of a herpetic infection. Both herpes simplex and herpes zoster can cause peripheral corneal melting, and it's an important, you cannot differentiate one from the other unless you do viral cultures. Okay. So these should be in the differential diagnosis before you give immunosuppressive therapy or even steroids, and this is an important issue in your differential. The second point that I would like to mention is that you mentioned doxycycline. The available dose in the States is 50 milligrams, and I don't think we have.
We do have it. It's available in the Ministry of Health formulary.
Yeah. 50?
Yeah, 20.
20.
20 milligrams.
50 milligram is the recommended. And as you mentioned, because we are not giving it as antimicrobial, but we are giving it for inhibition of the collagenases. And if you don't have doxycycline, 50 milligrams, you can give it every other day, and 100 milligrams every other day. So if you don't have it, because you cannot divide the dosage, these are capsules, and you cannot divide them. The reason why we use doxycycline or tetracyclines or all of these have a tendency to bind irreversibly to magnesium. And binding to magnesium is essential for the action of the collagenases. So you inhibit the collagenase by having the doxycycline bound to the magnesium. And this is how they act as inhibitors of collagenases. Of course, we used to call them collagenases. Now they are classified under matrix metalloproteinases. And the most common that we have is MMP2 and MP9 in these diseases. So collagenases is not used as we used to use it in the past. It's still the same, but they have now classified under the MMPs.
Okay. Thank you, Professor Tabara.
Doctor, you mentioned that herpes simplex virus and varicella zoster virus induce PUK through limbus vasculitis. I read about hepatitis C and its association with the young onset PUK. Is it the same mechanism? Or?
In regard to hepatitis is associated with other diseases that can cause a PUK. It's not a hepatitis per se that causes the PUK.
The question about the association of hepatitis C with
PUK.
PUK.
Yeah.
This has been controversial and it is not confirmed. So there is no evidence-based medicine
True.
to suggest
True, yes.
that hepatitis C can play a role in PUK.
Assalamu alaikum, Dr. So how would you differentiate between, without the presence of uveal show
I can't hear you. ترى ما أسمعك.
without the presence of uveal show or scleral thinning, how would you differentiate between an active scleritis or reactory inflammation to adjacent PUK in the same patient?
I did not get your point.
So you would expect that a sclera adjacent to a PUK to be inflamed.
Yes.
How would you differentiate between presence of scleritis or just inflammation because of an adjacent PUK?
Because of what? Because of what? Yeah, scleritis. You will usually have pain with scleritis. You will have involvement of deep tissues. When you put your slit lamp, you can see scleral inflammation and involvement. You sometimes have overlying epithelial defect on the inflamed area as you see in necrotizing scleritis. In cases that is associated with scleritis will be very evident, especially in severe cases. In the early cases, you might overlook it and miss it. But there is, I'm not aware of a technique that you do. You can differentiate exactly in the early stage of an inflammation if that is a scleritis or just an adjacent congestion of a limbal vessels. Any other comment, question?
I think we need more research in terms of the pathogenesis of some of these cases with PUK. In the late 80s, we have put a book on peripheral corneal disorders. And this was published by Little Brown and Company in Boston with Dr. Vincent DeLuise and I. We put this book. And if I read it now to you, there is no new knowledge
True.
about peripheral corneal disorders. It's exactly what you gave us. So I think we need to do more investigations or clinical research or improve our clinical observation or the pathogenesis of the peripheral corneal melting. Why in some patients it occurs and others they don't,
True.
and so forth. And the thing is that some of these cases with rheumatoid arthritis may develop peripheral corneal infiltrates without melting. Yet others may go to melting before
Without
they get the infiltrates.
True. Yeah.
And this is something that should be studied.
For many cultures.
What do you mean by tips of how to do scraping?
No,
Ah.
if it is a very thin area, so how
Okay.
can I take multiple times, multiple scrapings from the same thin area? If it is severely thin.
If the cornea is severely
Yeah.
thin,
And I'm afraid to do
yeah,
perforation.
of course you don't use the Comura spatula to scrape it harshly. We have a blunt form of Comura spatula. You can also use the soft cells or soft wax cells to scrape the cornea. But if you have a doubt that you will
Yeah.
perforate, then you should call a senior colleague
Uh-huh.
who can just handle it. Especially in a deeply melted corneas.
Yeah.
Sometimes you can see there is a desematocele underlying a melted cornea that is opaque, so you don't see it. So sometimes with a minimal pressure, you can just rupture that area.
And you still advise to take scraping? even
No,
by
scraping is important to rule out an overlying infection or a super infection of the existing melting. But gentle scraping is always possible. It's not a contraindicated to touch the eye gently and scrape some tissues and send it for culture. Yeah.
I would like to ask about the therapeutic PKP or therapeutic keratoplasty. For how long you will wait for the inflammation to halt?
You sometimes can't get the inflammation under control. And that's the time you go for a tectonic graft. The reason for going to tectonic graft is you would like to save the integrity of this globe. Once you have an impending perforation with an ongoing inflammation, not responding to treatment, you will go for PKB or lamellar graft or crescentic graft, regardless of the outcome, because your outcome is not optical. It's not for the patient to see better. It's for this eye not to be perforated and get a secondary complication of perforation. So it's not a prerequisite that you should have a completely quiet eye before having the graft. It's an important for the graft survival.
Yes.
Yeah.
Okay. So the second question regarding AMT used in PUK. So the technique of AMT, is it better to put the epithelial up or down?
I found no single evidence that epithelial up, epithelial down has any role on the outcome. It has been postulated that if you have a stromal disease, then you put stroma down.
Yes.
So stroma will be incorporated to the corneal stroma and will form a new surface with a good basement membrane. If you would like it to have an AMT for just bandage effect, then you put the basement membrane down and the stroma up. I found no single evidence supporting this recommendation. Yeah.
Thank you.
Thank you.
Thank you, Doctor, for this informative lecture. If we have a patient, a known case of autoimmune disease, controlled by medication, for example, steroid, and he developed the PUK for the first time, is it important to work him up to rule out the infectious causes of PUK at this time, or just give him, increase the dose of the steroid and watch the result?
And why does that patient is on steroid?
For his known case of immune disease, for example, rheumatoid arthritis, and he developed PUK for the first time.
Okay.
Is it important to work him up to rule out other infectious causes of the PUK?
Infection has always to be ruled out.
Yes.
Has always to be ruled out regardless of the existing condition of the patient. Because infection can happen regardless of anything. But if you have somebody with an already diagnosed autoimmune disease that is known to cause peripheral corneal degradation, then you don't need to look for a second diagnosis. But you should always make sure that this patient does not have a superimposed infection. He's also on steroid, he's relatively immunosuppressed. So this has to be looked at. I wouldn't investigate more for on the line of autoimmune disease. I would look for a secondary superinfection. I will treat it like corneal ulcer. Okay. Thank you very much, everybody. تسكر الشاشة.
دكتور اسكت.
شاشة خليها صوت الحين.
حطلع من الأرض من هنا. بس أنت بتبصرها يا دكتور؟
إيه.
ماجد. جبنا هنا موية. شكرا الله يحفظك. شكرا لك.
Bismillahirrahmanirrahim. Assalamu alaikum. Good afternoon, everybody. I'm Dr. Noor Al-Kureji from King Saud University Hospitals. Today we'll be having an important uveitis topic, which is Vogt-Koyanagi-Harada disease, covered by Ahmed Abu Asrar, Professor of Ophthalmology in Retina and Uveitis Specialties and Chief of the Vitreoretinal Division at the Ophthalmology Department at King Saud University Hospitals. البروف أحمد غني عن التعريف طبعاً. I am sure that every ophthalmologist will appreciate the importance of this topic and this common uveitis entity that might lead to irreversible blindness. Without further ado, Professor Ahmed, تفضل.
Assalamu alaikum. In fact, I was not supposed to give the grand round today. The grand round was supposed to be given by Professor Ghezlan Abdanakar, Director of Microbiology Immunology Division of Riga Institute for Medical Research, who was supposed to arrive last Saturday. But unfortunately, his mother was admitted to the intensive care during the weekend, and unfortunately, she passed away Sunday morning. So when he called me, what should he do last Thursday, I told him, it's better to stay with your mother during her last days. So hopefully he can come the next few weeks and to talk about a very important topic that he was supposed to discuss on chronic wound healing. So today I updated my lecture on Vogt-Koyanagi-Harada disease and added new of our data, and I thought that it's an important topic and we have important information that I want to share with you today. So we have a special interest in Vogt-Koyanagi-Harada disease. If you look around in the world, you will see few people have a special interest in this disease, because it's a disease that if you manage properly at initial presentation, I mean during the initial acute phase of the disease, you can prevent a lot of complications. If you miss the disease and you leave the disease to progress into chronic recurrent disease, it becomes like a malignant disease with all the complications that you see in uveitis developing in these patients. So to start with, uveitis with Vogt-Koyanagi-Harada disease is an autoimmune disease. And the autoimmunity is directed against one or more antigens found on or associated with uveal melanocytes. So it is a bilateral granulomatous panuveitis. But the inflammation, everyone in this room should know that the inflammation is primarily at the level of the choroid. The exudative detachment is a secondary phenomenon. So the exudative detachment is the result of the granulomatous inflammation at the level of the choroid. Now, these patients, in the prodromal phase of the disease, they can have central nervous system and auditory signs. So the central nervous system and auditory signs are seen in the prodromal phase of the disease. But skin and hair manifestations like bullosis, vitiligo, and alopecia are never seen at presentation in the initial acute phase of the disease. They are seen later on in the chronic recurrent phase of the disease. That's why this classification or criteria for diagnosis, complete and incomplete, many authorities in the field don't agree with it. It's a misleading criteria when you say if the patient had skin and hair manifestations and this is complete, but all the patients at initial onset disease, they never have a skin and hair manifestation. This will develop later on, if you allow the disease to progress into chronic recurrent disease by inadequate immunosuppressive therapy, then the patient will develop these changes. The prevalence of the disease varies among different populations of the world, and it commonly affects pigmented races and people of certain genetic predisposition. So there is a genetic predisposition, there is association with HLA-DR4 and HLA-DRW53. As I said, it's an autoimmune disease involving T lymphocytes. It has been shown that T lymphocytes are belonging to T helper 1 and T helper 17 cells producing interleukin 17. And the antigens that were identified are tyrosinase family of proteins. So these are the antigens associated with melanocytes that are attacked by the T lymphocytes. It is the most common, VKH is the most common uveitic entities in the kingdom. Everyone in this room should know this. We proved this in two studies that at least in our university hospital as a referral center for uveitis, it is the most common cause of uveitis in our hospital. The visual prognosis is generally excellent with early proper treatment. So this is the most recent paper that we published with Dr. Huda Dahri, where we showed that, in which we showed that VKH was the most common uveitic entity, followed by presumed tuberculous uveitis, followed by Behçet disease. Everyone in this room should know by heart this slide. When a patient presents very early in the course of the disease, what we call it initial onset acute disease, the only manifestations of the disease are granulomatous choroiditis with a secondary exudative retinal detachment, optic disc hyperemia, and swelling. No anterior segment inflammation. Have you seen this, Yanura? So everyone should know that in the initial onset acute uveitic phase, very early, after presentation, there is no anterior segment inflammation. There is no cells, no matum fat capiz, and most of the residents who rotated with us should have seen this. That's why many of these cases are misdiagnosed by our colleagues as like central serous choroidopathy, because they don't know that the patient, when present early, there is no anterior segment inflammation, or frequently misdiagnosed as pseudotumor cerebri because of optic nerve head swelling and hyperemia, and of course the headache, and they refer the patient to neurology, and the patient unnecessarily undergoes lumbar puncture and MRI. We have seen many cases like this. So everyone in this room should know that very early after the onset of disease, the hallmark of the disease is only optic disc inflammation and exudative retinal detachment. Then if the patient is not treated at this stage, as it happens very frequently, then the patient will develop anterior segment inflammation in addition to the exudative retinal detachment and optic nerve inflammation. So the patients will have anterior chamber cells, matum fat keratic precipitates. Now, at this stage, what I call it delayed presentation, initial onset, still in the initial onset acute uveitic phase, the exudative detachment is usually very bullous. And the treatment of these patients, the detachment needs weeks to resolve when it becomes bullous. Then, if the patient is not treated properly, the patient or received inadequate immunosuppressive therapy, the patient will progress into chronic recurrent granulomatous anterior uveitis with iris nodules, matum fat keratic precipitates, significant anterior inflammation associated with sunset glow fundus as a stigmata of chronic recurrent disease. Why this is important? Nowadays, in collaboration with many colleagues in Brazil, in Argentina, in Europe, we are trying to meet and to revise the diagnostic criteria. And it's very important that if you label the disease initial onset without anterior segment inflammation, initial onset with anterior segment inflammation and the chronic recurrent phase is very important for therapeutic trials. Because many of the studies, they lumped all these three forms together, and the results were, or the conclusions were misleading. Because the outcome of the treatment, when the patient presents with no cells in the anterior chamber, is excellent. The outcome is less favorable when the patient presents still in the initial onset, but with cells and reactions in the anterior chamber. And the outcome is worst if the patient is left to progress into chronic recurrent disease. Then I'll come to a very important concept nowadays in autoimmune conditions, which is therapeutic window of opportunity. We believe that if we catch the patient very early in the course of the disease, what we call it during the therapeutic window of opportunity, we can cure VKH disease and we end with completely normal eyes. So what is therapeutic window of opportunity? In fact, this concept started with rheumatoid arthritis, but now many studies show that it is also applicable for other autoimmune inflammatory conditions like inflammatory bowel disease, ankylosing spondylitis, and so on. So what is this therapeutic window of opportunity? So therapeutic window of opportunity is a well-established concept of critical importance in rheumatoid arthritis, and considerable attention has been paid to when it might close. In rheumatoid arthritis, they believe that it might close within few months after the onset of the disease. So this window represents a very early phase of the disease in which therapeutic disease modification is more successful, presumably because the disease process is not fully matured. So if you start a treatment at this stage of the disease, then you can cure the disease and induce long-term remission. A growing body of evidence has emphasized the consistent clinical and radiographic benefits of prompt institution of disease-modifying anti-rheumatic drugs in patients with rheumatoid arthritis during the early stages of the disease. Therapeutic intervention in this period alters the natural history of the disease and hampers disease progression in such a way that chronicity is reduced, so you avoid chronicity. Furthermore, early intervention results in greater proportion of patients in drug-free remission after treatment withdrawal and reduces mortality rates. These findings have led to changes in rheumatoid arthritis treatment paradigms with increasing emphasis on early diagnosis and treatment. So the secret here early diagnosis and treatment before maturation of the disease process. Then we have data to confirm that in VKH we have this concept of therapeutic window of opportunity is present. So if this window of opportunity exists in Vogt-Koyanagi-Harada disease, this has important consequences for the care of initial onset acute uveitis associated with Vogt-Koyanagi-Harada disease, as using this period will reduce the burden of the disease and substantially alter the outcome by delivering the right syrups at the right time. Based on our experience, we believe that this therapeutic window of opportunity in VKH is within the first 2 weeks after the onset of the disease. So we have 2 papers, 2 publications that supported this concept in Vogt-Koyanagi-Harada disease. So this is the last paper that we showed that in, the use of mycophenolate mofetil combined with systemic corticosteroids as a first line of treatment. During the process, we are writing now a review article. It's that authored by many authors from Japan, from Brazil, from Argentina, from Singapore, from Europe, that to support that catching the therapeutic window of opportunity can improve the outcome in Vogt-Koyanagi-Harada disease. And this is one of the papers that we discussed in this review, in which we showed that the primary use of mycophenolate mofetil as immunomodulatory agent with systemic corticosteroids, I mean by primary use at the onset of the disease. Many people, they use immunomodulatory therapies 6 months or more if steroids are not working. This is not correct. If we are talking about primary treatment, it means that from the onset of the disease. And we showed that the combined use of mycophenolate mofetil as an immunomodulatory agent combined with systemic corticosteroids can improve the outcome, preventing the progression to chronic recurrent disease and preventing sunset glofundus and other complications. This was also the first paper that we published. And then in this paper, we discussed the indocyanine green angiographic findings in initial onset acute VKH that can help also to make the diagnosis. So for everyone to know how initial onset acute VKH present, as I said, very early in the course of the disease, if the patient presents within few days, no cells in the anterior chamber, no matum fat kibis, no iris nodules, completely clear vitreous. But the hallmark of the disease is a shallow oxidative retina detachment, as you can see here, involving the posterior retina. The moment that the detachment becomes bullous, involving the inferior retina, it is still initial onset but delayed presentation. Because, as you can see here, this is how initial onset disease present. The patient have a shallow oxidative retina detachment involving the posterior retina. And this is the typical fluorescein angiography with pinpoint leaks and pooling of dye under neurosensor retina. And this is a typical ICG where you see multiple hypofluorescent spots corresponding to choroidal granulomas and diffuse hypofluorescence corresponding to oxidative retina detachment. This is another case. This is another challenging case. Again, this case was thought to have central serous choroidopathy. But you see here a very shallow oxidative retina detachment in the central retina, but the optic disc is inflamed. And then if you look at the fluorescein angiography, there is prominent inflammation of the optic nerve. So fluorescein angiography here is very useful because in central serous choroidopathy, you don't expect to see inflammation of the optic nerve. And we always say that if there is no optic nerve inflammation, it is not VKH. So the presence of optic nerve inflammation is very important for the diagnosis of VKH. So the patient, because this is a very early presentation, you can see few pinpoint leaks and pooling of dye under the neurosensor retina, and the same also here. But this is very early presentation. But here, look here. The ICG is more impressive. Many black spots corresponding to the granulomas. And this is hypofluorescence is corresponding to the oxidative retina attachment. So this is how we should diagnose initial onset acute VKH. This is another example of more bullous detachment, and frequently we see hemorrhages in patients with VKH, intraretinal hemorrhages. And this is another case, again, to show you the very limited oxidative retinal detachment on those patients with very early presentation in initial onset acute VKH. Now, how chronic recurrent VKH present? Look here, big difference. Matum fat cratic precipitates, sunstick glofundus, peripapilloid retinal atrophy, subretinal fibrous bands. So these are criteria to diagnose chronic recurrent VKH at presentation. Granulomatous anterior segment inflammation, the posterior segment, sunstick glofundus with chororetinal scars, and subretinal pigmented fibrous bands. Another case. This is granulomatous anterior segment inflammation, posterior synechiae, sunstick glofundus, and then look at the fundus. This is another case of chronic recurrent VKH. Matum fat KPs. Frequently, we see iris nodules. As you can see here, these are whitish fluffy nodules. And it's also clear here. So chronic recurrent VKH present as granulomatous anterior segment inflammation with sunstick glofundus. So everyone should know that chronic recurrent VKH disease is significantly associated with more severe anterior segment inflammation. It is very resistant to treatment in many patients. So the anterior segment inflammation is very severe, very resistant to treatment, and the chronic recurrent disease is associated with a worse visual acuity and diminished retinal sensitivity, as I'm going to show you. Now, Chinese studies using laser flare cell meter demonstrated that both aqueous flare values and cell counts were significantly higher in patients with chronic recurrent VKH disease than those with initial onset acute VKH disease. And the chronic recurrent VKH is more effective treatment. So again, this is very important when it comes to therapeutic trials, that you have to know which disease included in each arm. If you want to have a homogeneous group of patients, then you have to have patients with initial onset acute VKH without anterior segment inflammation, because this is very early presentation. Because the timing to start immunosuppressive treatment plays a major role in the response to treatment. When the patient reaches to the stage of chronic recurrent, you cannot really lump together chronic recurrent disease with initial onset acute VKH. Many studies show that vision-threatening complications occur in the chronic recurrent phase of VKH disease, and these are cataract, glaucoma, subretinal neovascular membrane, subretinal fibrosis, chororetinal atrophy, and sunstick glofundus. It is a malignant disease that destroys the eye. And the occurrence of these complications is known to be associated with a worse outcome. Many studies showed the association between chronic recurrent inflammation and the development of sunstick glofundus. Now, this is one of the papers. We looked at the prognostic factors, and this is the first paper in which we attracted the attention of the uveitis community that if you want to study prognostic factor of VKH, you have to divide the patients into two groups, chronic recurrent and initial onset acute VKH. Again, you cannot put the patients, you cannot put all the patients together. Chronic recurrent, initial onset VKH. And in this study, we showed that, as you see here in the table, we divided the patients into initial onset, We divided the patients into initial onset VKH and the chronic recurrent VKH. And you can see here the incidence of complications, all complications, cataract, glaucoma, subretinal neovascular membrane, was significantly higher in patients with chronic recurrent VKH. Sunstick glofundus, again, was significantly more in chronic recurrent VKH. And the visual outcome was worse in patients with chronic recurrent VKH. Now, when we looked at factors predicting 20/20 vision, the chronic recurrent VKH was a negative predictor for 20/20 vision, visual acuity. sunset glofundus was a negative predictor for the development of 20/20 visual acuity. And even on logistic regression analysis, the presence of sunset glofundus was a negative predictor for 20/20 vision. So meaning that if the patient develops sunset glofundus, I'm going to show also other data, it is a negative predictor for good vision and also macular sensitivity. Then when we looked at the rate of complications, initial onset VKH had significantly less complications, sunset glofundus associated with more complications. And then when we did logistic regression analysis for factors predicting complications, the chronic recurrent presentation was associated with the complications. What is important here, that patients who present with chronic recurrent anterior segment inflammation with sunset glofundus, people might consider that the inflammation is limited to the anterior segment, which is not correct, because indocyanine grain angiographic studies showed concomitant subclinical inflammation at the level of the choroid in patients who are presenting with granulomatous anterior segment uveitis, in patients with VKH. And the Japanese researchers, they did histopathologic studies in patients with sunset glofundus, and they could identify the presence of T lymphocytes in the choroid of patients with sunset glofundus. What does this mean? It means that in patients with chronic recurrent VKH, they have subclinical choroidal inflammation due to inadequate immunosuppression, and this chronic subclinical inflammation will lead to sunset glofundus. So as I said, the development of sunset glofundus is associated with the development of any complications of cataract, glaucoma, of subretinal neovascular membrane. Therefore, all our efforts when we see patients with initial onset acute VKH should be done to prevent the progression into chronic recurrent inflammation and to prevent sunset glofundus. Therefore, the main goals in the management of initial onset acute VKH disease are to suppress intraocular inflammation in the acute posterior uveitis stage at the level when the disease is still limited to the choroid, and to prevent the progression to chronic recurrent intraocular inflammation. And many studies, I'm going to talk about these studies in detail today, that showed that despite appropriate treatment with early high-dose systemic corticosteroids, many patients develop chronic recurrent granulomatous inflammation and progressive depigmentation of the fundus, resulting in sunset glofundus appearance even after clinical disease appears to be under control. So these studies concluded that corticosteroid monotherapy is not effective in patients with Vogt-Koyanagi-Harada disease. So I'm going to give a summary of this study. This is a study by Sakata et al. They showed that despite early high-dose corticosteroid therapy within 3 days, within 30 days from disease onset and the slow tapering, about 80% of the patients with VKH progress to chronic recurrent disease, and 40% develop subretinal fibrosis. So the conclusion of this study is that systemic corticosteroid monotherapy is not effective in initial onset acute VKH. In another study by Dr. Chi, they showed that about 1/3 of patients receiving high-dose corticosteroid therapy within 2 weeks of onset progress to chronic recurrent disease. So this is another study to tell us that a good number of the patients, despite high-dose systemic corticosteroids, they progress into chronic recurrent disease. Another study by Dr. Kainu and associates showed that despite high-dose corticosteroid therapy at initial onset, about 18% of the patients developed chronic ocular inflammation. Now, the other studies, they looked at sunset glofundus. So in this study, Dr. Kainu et al., they followed about 100 patients with VKH disease from initial onset who were treated with high-dose corticosteroid therapy. Sunset glow fundus develop in about 70% of the patients, despite high dose. But when do you expect to see sunset glow fundus? The mean time to develop sunset glow fundus is 4 months. So sunset glow fundus will be seen after a mean period of 4 months from the onset of the disease. Another study shows the development of sunset glow fundus in 51% of the patients who received oral corticosteroid monotherapy during the first attack of VIH. So there is agreement nowadays that systemic corticosteroids monotherapy is not enough to prevent chronic recurrent inflammation and to prevent sunset glow fundus. Therefore, the poor visual prognosis associated with chronic recurrent inflammation, if you leave the patient with chronic recurrent inflammation, we know that the visual prognosis is worse. And because of the systemic complications of long-term high-dose corticosteroids, I always say that systemic corticosteroids are the worst drug you can treat a patient with. It's very toxic, but it has the advantage that it acts very fast. So we use this advantage that steroids act very fast at the initial treatment to control the inflammation, and the control of the inflammation can be continued later with the immunomodulatory therapy. So this is a list of studies that tried cyclosporin, azathioprine, methotrexate, mycophenolate mofetil early in the course of the disease to improve the outcome. And one of the most important goals in using non-steroidal immunomodulatory therapy in non-infectious uveitis is to minimize exposure to corticosteroids and reduce corticosteroid levels. That's why those of you who rotated with us, you will never see patients coming with cushingoid face. You will never. Because of this concept that we use steroid-sparing agents in patients with uveitis to limit the use or the dose of systemic corticosteroids. And several studies reported that mycophenolate mofetil is safe and effective as corticosteroid-sparing agents in patients with non-infectious uveitis. It is an antimetabolite which has a broad safety profile compared to other immunomodulatory agents. So this is the study in which we proved the concept of therapeutic window of opportunity in VIH. So in this study, that was 38 patients. All the patients presented with initial onset acute uveitis associated with VIH disease. And we evaluated in these patients the combination of systemic corticosteroids and mycophenolate mofetil as first-line treatment. From the onset of treatment, we add mycophenolate to steroids. And we have long-term follow-up. All these patients are already in our files. And if any one of you come to our clinic, we have a lookbook. Perhaps, Noura, you know about this lookbook, Iman. And in the lookbook, we have, it's a lookbook for VIH disease. So all the reasons, lookbook for VIH disease. We record all the cases, and all the cases are labeled as acute initial onset or chronic presentation. And then if you come to the clinic, you, in our ImageNet system, in each room, you just put the file number of the patient, then you will have the clinical photo at presentation, fluorescein angiography at presentation, ICG at presentation, and at different follow-up visits. Sometimes I challenge the residents when I show them a patient who I told them we cured him from VIH. Look at the fundus. What do you see in the fundus? And then ask, is there anything abnormal? They said, no, this is a normal fundus. We could achieve a normal fundus in these patients. So I encourage every one of you who is interested to look at this data is to come to the clinic. Within 2 hours, he can review like 40 patients, just put the name of the file number of the patients, and he can see how the patient presented and what was the fundus picture at the last follow-up. I think one of these patients, where is Dr. Abrar? Yeah. I showed Abrar last, she is rotating with me right now, a patient with complete normal fundus. I told her, and the patient in no treatment, he completes the treatment. And she said the fundus is normal. Yes, you can have a normal fundus in the patient if you treat very early in the course of the disease. So we, in this study, 38 patients, we compared the outcome in a group of patients, historic control, patients that we published before some years ago, that were receiving only systemic corticosteroid as a primary treatment, and immunosuppressive were given later. So all the patients, we have a fixed protocol in our department. So the patient receives systemic corticosteroid combined with mycophenolate mofetil 2 grams daily. And of course, for pediatric populations, the dose is adjusted accordingly as first-line therapy. Corticosteroid therapy began with intravenous pulse steroid therapy, which is methylprednisolone, 1 gram daily for 3 doses. And the dose is adjusted according to the pediatric age group. We have good number of children with VKH. And then after 3 days, we shift the patient to oral prednisone, 1 milligram per kg of body weight, and we keep this dose for at least 3 weeks. Then gradually, the prednisone dose is gradually tapered following improvement of the intraocular inflammation, and our aim is to reach a maintenance dose 10 milligram or less. Mycophenolate dose was also tapered for after the patient had complete remission to a maintenance dose of 500 milligram per day. All the patients, those of you who rotated with us on the chart, the patient had 2 appointments. 1 appointment in uveitis clinic and 1 appointment with the internist. So the clinical status, blood cell counts, liver and renal function tests were checked by internists every 6 weeks during the period of treatment. It's heavy responsibility when you give the patients immunosuppressive therapy like this on our side, and our clinic is very busy to review all the lab results of the patient. So all the patients we have a protocol hospital are seen by our internist. And they know how frequent should we do these lab studies. So a corticosteroid-sparing effect, as you know, is defined as reduction of the prednisone dose to 10 milligram per day or less while maintaining an active uveitis, and time to achievement of the effect were assessed. Taban, you know that this is our protocol. The patient during the first 3-4 months of initiation of treatment, they have what's called intensive care follow-up. The patients are seen every 2 weeks in the clinic, because this is a very critical period. And also you have to know that a drug like Cellcept will take like 8 weeks to act. During this period of the first 8 weeks of studying the treatment, you have to be careful with the tapering of the systemic corticosteroids. So we had 38 patients. All of them had initial onset. That's very important. Initial onset acute uveitis with VKH disease. There were 21 males, 17 females. The mean age at presentation was 27 years. So it is a disease of young people. But also, 16% of the patients were pediatric, 16 years of age or younger. And the pediatric group, they did as good as the adult group. There was no difference. All the eyes had exudative retinal detachment with optic nerve hyperemia and swelling. The mean interval between the onset of the disease and the starting treatment was 10 days, and the median was 7 days. So this is very early. Again, just to remind you, with the acute onset, these are the cases included in the study. You see, only you have optic nerve head hyperemia and a shallow exudative retinal detachment with completely normal anterior segment. The follow-up ranged from 9 months to 120 months. So we have a follow-up up to something like 10 years. And the mean follow-up period was 37 months and median 27 months. None of this patient missed his appointment during the follow-up period. None of the patient developed systemic adverse events associated with the treatment. But what frequently, the medical doctor sometimes calling me, the patient had slightly elevated liver enzymes. Then we discuss the case, and we can taper or reduce the dose of mycophenolate mofetil in some of these patients. When you look at the visual outcome, 3.4% of the achieved the 20/20 visual acuity, and 4 patients, or 4 eyes, 5.3% achieved the vision 20/30 to 20/40. So the visual outcome was very good. And the prevalence of best vision 20/20 significantly increased from 26% at presentation to 93.4% at the last follow-up. And the prevalence of worst vision 20 to 100 or less reduced from 33% at presentation to 0% at the last follow-up. What is more important here, that none of the eyes progressed to chronic recurrent granulomatous enterouveitis. The ocular complications encountered were glaucoma in 2 eyes that was controlled by medical treatment, and the cataract in 5 eyes that was controlled, that needed cataract surgery, 6.6% of the eyes. If you look at, we have a paper that we shall submit soon on cataract in uveitis, and you will see that VKH was the most common cause of cataract that needed surgery in our hospital. But this is because of the chronic recurrent patients, the risk of cataract is very high. None of the eyes developed suncyclical fundus. Somebody might be surprised, but I would invite everyone who will doubt this data to come. I'll give him the file number. He can sit on the ImageNet system and look at the patient at presentation and at the last follow-up. 2 patients developed vitiligo and bullosis. So these are examples. I cannot show you the 38 patients, but I'm going to show you some examples. This is a patient at presentation, and this is 54 months after treatment. And this patient was off treatment for 16 months without relapse of inflammation. We cured the disease. We used the therapeutic window of opportunity, which is a very important concept now in VKH disease. So this is another patient. You can see at presentation the exit retinal attachment, and then 36 months after treatment. So this is 3 years after treatment, and the patient is off treatment for 12 months without recurrent inflammation. This is a third example at presentation, and 30 months after treatment and off treatment for 12 months. So the corticosteroid-sparing effect was achieved in all patients. The interval between starting treatment and tapering prednisone to 10 milligram or less ranged from 3 to 7 months with a mean of about 4 months. So this is the interval. So after a mean of 4 months, we were able to taper the prednisone dose to 10 milligram or less thanks to mycophenolate mofetil. During the study period, 60% of the patients were able to discontinue treatment without relapse of inflammation, as I showed you. And in those patients who discontinued treatment without relapse of inflammation, the mean duration of steroid therapy was 18 months, and the median 17 months. And the duration of mycophenolate treatment in those patients who stopped the treatment without relapse of inflammation, the mean was 20 months and the median 20 months. And this treatment were off treatment without relapse of the inflammation for a mean period of 25 months. When we looked at in our historic group that we published many years ago, all these patients who use systemic corticosteroids alone develop sunset glow fundus, and these are examples. We don't see this anymore in patients who present with initial onset. You see the sunset glow fundus appearance, the onychia, and the chorioretinal scars that are typically seen in VKH. This is another example of peripapillary chorioretinal scars, and choroidal neovascular membrane. And this is another example of iris nodules because of anterior segment inflammation, granulomatous inflammation, peripapillary atrophy, and chorioretinal scars. What was interesting here that none of the patients in the corticosteroid mycophenolate mofetil develop vitiligo, biliosis, alopecia, or sensory hearing loss. In the corticosteroid group, this is in our previous publication, 50% developed sensory hearing loss, because at that time we were referring all the VKH being Dr. Saraya Dusari to do audiogram for them. And 33% developed vitiligo, 20% developed alopecia, and 10% developed biliosis. So this disfigurement that we used to see in the past of vitiligo involving the face, we don't see it anymore. Then there was an argument that a patient with sun-sick fundus can have 20/20 vision. So why you are not happy? For a long time, we believe that this 20/20 vision or Snellen visual acuity is not reflecting the damage that happens to the macula. So we decided to use microperimetry, which is a much better way to assess macular function. And then when we looked at microperimetry in patients with initial onset VKH versus chronic recurrent VKH, the microperimetry sensitivity was significantly better in initial onset VKH compared to chronic recurrent VKH. And when we looked at sun-sick fundus, the mean microperimetry values was 5 decibels, and without sun-sick fundus, 9.4. These are examples. This is initial onset acute VKH. So this is a patient 72 months after treatment. And then you can see the sensitivity 11.9, 11.7 decibels. Another patient 36 months after treatment, sensitivity 10 decibel, 10 decibel. Now look at this case. This is chronic recurrent VKH with sun-sick fundus. The vision 20/30, 20/30. Everyone will be happy with this vision. But if you look at microperimetry, 5 in the right eye and 1.9, despite that the vision is 20/30. This is another case. You can see the sun-sick fundus scars, 6 and 1. So despite that some patients with sun-sick fundus can have excellent vision, but the sensitivity is significantly reduced. And that's why we published this review. The authors of this review, Dr. Ahmad from Brazil, Carlos Bavizio from Moorfield Hospital, England, Vishali Gupta, Khairallah from Tunisia, Iknor from Turkey, Swalian from Iran, and Takayuchi from Japan, and Dr. Marina from Italy. So that just to attract the attention of the UVETS community that sun-sick fundus that was thought in the past to be a part of the natural history of the disease is not correct. Everyone should know that sun-sick fundus is the result of inadequate immunosuppression or delayed immunosuppression treatment leading to chronic subclinical inflammation at the level of the choroid. So conclusion, this is not the final conclusion, I still have other data. The use of immunomodulatory therapy in the form of mycophenolate mofetil as first-line therapy combined with systemic corticosteroids in patients with initial onset acute VKH disease prevents progression of the disease to chronic recurrent disease and development of complications, including sun-sick fundus. Now, I might be asked, is mycophenolate mofetil is the only treatment? No, in our experience, but we have 2 patients that we did not include in this study. These were 2 women who were pregnant at presentation. And of course, for this woman, you cannot use mycophenolate mofetil because it is teratogenic, so we use cyclosporine, and we achieved the same response. So it seems that combining steroid with immunomodulatory agents like mycophenolate, cyclosporine will be equally effective. So similar to rheumatoid arthritis, so our data are very similar to rheumatoid arthritis concept of therapeutic window of opportunity. Early in the course of uveitis associated with VKH disease, a therapeutic window of opportunity might exist, in which mycophenolate mofetil therapy combined with systemic corticosteroids could change the disease course, alter natural history, substantially reduce damage, and result in drug-free remission after treatment withdrawal. Moreover, early intervention with adequate immunosuppression in patients with initial onset acute uveitis associated with VKH disease can reduce the development of skin, hair, vitiligo, and alopecia manifestation. Now, we have relatively new data that we published already in the Investigative Ophthalmology and Visual Science, looking for biomarkers of disease. And this data were confirmed in another study that we submitted when we looked also at other CXC chemokines. So we were interested to look at the role of lymphoid chemokines in uveitis. So we know that this is again a relatively new concept, that B lymphocytes play an important role in the pathogenesis of autoimmune diseases. And this has been shown in Sjogren's syndrome, multiple sclerosis, rheumatoid arthritis, myasthenia gravis. So B lymphocytes are playing a major role. And in this condition, there's what's called ectopic lymphoid aggregates with germinal center-like structure in the inflamed tissue, in the synovial tissue in patients with rheumatoid arthritis. You have ectopic lymphoid aggregates, which contains proliferating B lymphocytes, plasma cells, follicular helper CD4 positive T lymphocytes, and network of follicular dendritic cells. So this is an important concept nowadays, the role of B lymphocytes and ectopic lymphoid aggregates in the pathogenesis. So the formation of this ectopic lymphoid structure depends on certain chemokines that chemo attract and activate B lymphocytes. One of them, which is very important, CXCL13, which act on a receptor called CXCR5. And there are the other four. And these are the references. So we looked at this lymphoid chemokines in patients with different specific uveitic entities. And we could see that the CXCL13, which is a major chemoattractant for B cells, was significantly high in VKH disease compared to Behçet and HLA-B27 associated uveitis. And this is the data in the new study that we recently submitted, in which we showed that, again, this is pathological studies in some cases of granulomatous uveitis, including our studies, that showed that B lymphocytes are present in the choroid of patients with this granulomatous uveitis, such as sympathetic ophthalmia, multifocal choroiditis, progressive subretinal fibrosis, and VKH disease. And this is from our paper we published some years ago. This is from sympathetic ophthalmia eyes, and you can see a heavy and mononuclear cell infiltrate in the choroid with multinucleated giant cells. But when we look at the staining, these are T lymphocytes, but look here, B lymphocytes, large aggregates of B lymphocytes, suggesting that our data on CXCL13 chemokine is consistent with the presence of many B lymphocytes in the choroid. And what does this mean? It means that biologics that target B lymphocytes would be effective in patients with chronic, recurrent, resistant Vogt-Koyanagi-Harada disease. And we know that a drug called rituximab is a biologic that targets CD20, leading to depletion of B lymphocytes. Might be effective in patients with chronic VKH. Based on this, we requested approval from the College of Medicine to use rituximab for chronic recurrent VKH resistant to treatment. They give approval for 5 patients per year. It's a very expensive drug. And you give the drug at 3 doses, first dose after 2 weeks, and then the third dose 6 months later. So that was a very unfortunate patient. She was a young student, university student. She even became depressed because of the chronic nature of the disease. I have a lot of sympathy with this patient. And that was not her fault. She came to a very important uveitis facility. According to her, they never treated her. They gave her drops and they sent her. So when she came to us, she had this very aggressive anterior segment inflammation with posterior synechiae, and the patient had multiple YAG iridotomies to treat glaucoma and so on. So she had, and then I discussed with her if we can start, if we give her rituximab, and rituximab allowed us to control the inflammation. This is here after inflammation, and you can appreciate the YAG iridotomies that was done several times to control pupillary blood glaucoma. And more recently, she underwent cataract surgery under the care of Dr. Abdullah Al-Fawaz. And Dr. Al-Fawaz, he is doing a great job because the way that he operates the cataract in these patients is very excellent. And we are also publishing the outcome of cataract surgery in patients with uveitis. We have, compared to the literature, a very good outcome. So this is another patient. So far, I treated with rituximab 4 patients with chronic recurrent Vogt-Koyanagi-Harada disease. So this is the last slide that I wanted to show you today. And do you have any questions? Mohammed.
Thank you for this nice lecture. I have a question about the stopping the mycophenolate muftil for the VKH patient. Which patient you decide to stop medication for them, and on which base you decide?
You know, as I said, you have to know that all these patients are initial onset acute VKH who presented within few days. They don't have anterior segment inflammation. So after, as I said, after a mean follow-up of about 20 months, we were able to stop mycophenolate mofetil. If the eye is completely, of course, it has to be done gradually. We start with 1 gram, 4 tablets per day, 2 tablets, 2 tablets. And then after 6 months, we can taper it to 3 tablets. After another 4 months, we make it 2 tablets, and so on. And then when we reach 1 tablet, we can stop it. So the mean mycophenolate treatment in this group of patients was this was like the 50% of the patient whom we could stop mycophenolate mofetil was about 20 months, and the mean corticosteroid therapy was 18 months. Okay, thank you very much for your attention. شكرا يا نور. الله يحفظك. Can we delete was it good?
go down. How do you get this down? Can you help get me somebody? Bring this podium down, please. Can you ask somebody from medical TV to bring this podium down, please? خلاص it's done. You don't need this computer, do you? To return to the respective institutions as contributors to our society's medical community. To our graduating fellows, let me add that it has been a privilege to participate in your continuing education and training, and I wish to thank you for your hard work, discipline, dedication, determination, and perseverance, and hope that you will carry these qualities in your areas of practice and will translate these into real strength and into superior service for your patients. To our medical staff, we also thank you. We thank you for your tireless efforts and long hours spent in teaching our fellows who will be the ophthalmology providers of tomorrow. Your dedication to convey wealth of knowledge and experience to these bright young minds is a testament to your professionalism and our professionalism, and a true mark of our noble profession, where the healer is also the teacher of the art. We wish all of you the best for your futures, which loom bright and full of promise, and we thank each one of you and every one of you, teacher and pupil alike. May your endeavors always be in the grace of God Almighty and in the service of humanity. Thank you.
Thank you, Dr. Nwelati. Now we'd like to invite Dr. Ala Mufti, Chief Fellow, to give a short speech on behalf of the graduate fellows.
Assalamu alaikum wa rahmatullahi wa barakatuh. His Excellency Chief Executive Officer Dr. Abdulaziz Al-Rashhi, Chief Medical Officer Dr. Saleh Misfer, Continuous Medical Education Director Dr. Sausan Nawailati, Chairman of the Saudi Scientific Committee Dr. Professor Khalid Tabara, ladies and gentlemen, أيها الحفل الكريم, السلام عليكم ورحمة الله وبركاته. بالبداية أود أن أتقدم بأحرى الآيات التهنئة والتبريكات للأهالي والأمهات والآباء لتخرج أبنائكم الأطباء والطبيبات من برنامج تخصص الدقيق لمستشفى الملك خالد تخصص للعيون. Thank you very much for joining us in celebrating our fellowship program graduates. 2 years ago, my colleagues and I have started a journey of a lifetime in this very own hall. Our mission was to walk into the footsteps to become highly qualified physicians and serve our community and country very well. And we are both excited and sad that this wonderful journey has come to an end. Throughout our fellowship, we felt that KKESH was more than a training institute. In fact, it was a nurturing environment, a second home, and indeed, a culture. We had a very supportive administration that aided us in achieving our goals, and we were privileged in working with extraordinary mentors who kept inspiring us to mature as responsible specialists in our designated fields. As we leave KKESH, we realized that our biggest gains were not only clinical and surgical skills, but rather that deep and special bond with our beloved mentors, staff, and great institute, a bond which we will connect us as colleagues forever, as in our heart for as long as we live. On behalf of our colleagues, we would like to express our thanks and appreciations to both Dr. Abdulaziz Al-Rashhi and Dr. Saleh Al-Misfer for the outstanding efforts in supporting the fellows training. We would like also to thank Dr.
بسم الله بسم الله.
Thank you to Dr. Ala, and we wish him the best of health. We'd like now to invite Professor Khalid Tabara, Chairman of Saudi Board of Ophthalmology, to say a few words.
I would like to thank Dr. Abdulaziz Al-Rajhi and Dr. Saleh Al-Misfer, Dr. Sausan Wailati, Dr. Iman Kahtani, who was with us before as Director of Medical Education, and Dr. Hassan Al-Dhibi, who is from a member of the board, Saudi Board of Ophthalmology, and also supervising the subspecialties within the board. This was a venture between King Khalid Eye Specialist Hospital and the Saudi Commission for Health Specialties, a venture that sponsored the subspecialties. We are hoping that the next step in the future to have boards in the subspecialties. Now we have the Saudi Board of Ophthalmology, but hopefully we will have boards in each of the subspecialties in the future. The Saudi Board of Ophthalmology has accepted the responsibility to train ophthalmologists and subspecialists. The ultimate goal is to cultivate and to transfer leadership to competent ophthalmologists. I take personal pride in being associated with this enterprise. We have gone a long way over the past 30 years, and today's graduates are the future ophthalmologists. In fact, they are the new generation of future ophthalmologists. Our goal has been the continued pursuit of new knowledge and skills in the subspecialties in ophthalmology, while striving to provide the highest standard of care in an academic milieu committed to educational and clinical excellence. Congratulations to our graduates. You have been rewarded and awarded for the hard work over the past 2 years. As we say, there is no sweet without sweat. Success is never final, however, and failure is never fatal. It's good to have so many gifts from the King Khalid Eye Specialist Hospital. The gift to be simple, the will to be free, the power to be clear, and the determination to be where we should be. Thank you.
Thank you, Professor Tabara. Now we'd like to invite Dr. Abdulaziz Al-Rajhi, our Chief Executive Officer at King Khalid Eye Specialized Hospital, to share his remark. Thank you.
Bismillah ar-Rahman ar-Rahim. Dr. Khalid Tabara, Dr. Saleh Al-Misfer, Dr. Salwa Al-Hazza, fellow colleagues and friends, thank you very much for joining us on this very memorable and cornerstone activity in KKESH history. I'm pleased to welcome you all to this year's graduating fellows of 2018. This is the 23rd batch of fellows with 25 graduates, and 2 of them, we're happy to say that they're from Kuwait. So welcome among your family and friends. And since its inception, King Khalid Eye Specialist Hospital has devoted great importance and emphasis in the academic education, training, and development of doctors in general and subspecialized ophthalmology to better serve our patients and our profession. This is a very important milestone for many of you. And I would like to take this opportunity to thank our colleagues and our fellow team members at KKESH, the consultants, the heads of departments, Dr. Iman Al-Qahtani, who was with you on the first year of your training, and Dr. Sausan Noelati, who helped you and mentored you during the second year of your training. And I also take this opportunity to wish Dr. Sami Shahwan, who will be taking up this role starting with the next batch. In ophthalmology, there is no one static goal. Your goal keeps on changing as you evolve and as you grow. I used to think when I was in medical school that graduating as a doctor is my goal. And then I discovered that I'm still at the beginning of the steps, on the first steps of the ladder, and I still have to climb and take my fellowship or my residency, sorry. And then I thought, okay, residency, and I'm an ophthalmologist. And then there was the fellowship. So I took the fellowship and I thought, okay, now I'm consultant. Now I am like anyone else and nobody can say anything. You know, I have the same authority. I can boss people around, shout and scream, and ask for nurses and ask to be treated special. And then I discovered that this is, again, nothing. If you don't keep on nurturing yourself, both on the academic level, on the scientific level, and on the human level, you're still not there. And you will never be there until you keep on trying to be a better person of yourself. Many of you have had these 2 years of training as a very positive experience. I'm sure some of you have had a few negative moments within that experience. Own it and make use of it. Whatever positive things you have seen done by your consultants and your mentors, please do like them. Imitate them and be better. The negative things that you've seen them do, please make sure you don't do them. And always remember, focus on your patients. They're human beings. One word from you makes a whole difference, might change their whole life. You telling them after a LASIK procedure, just to be sure, don't play football for 6 months. It changes their life, especially if this is his passion, if this is his hobby, or if this is his profession. For you, it's just a simple thing, just to be sure. You tell him, don't play football. Sometimes minimal comments that you might make on his eye condition, or you might kill hope that he might have for some improvement, might have a devastating effect on him. Procedures that you do, if you don't do it right, it will not only affect him and his future, it will affect his whole family. Mistakes that you've done because you were negligent, or you did not care, or you did not read enough, or you did not prepare for the procedure will affect a whole family, not only one individual. Take your responsibility very seriously. Finishing your fellowship does not mean that you are a consultant. That's just a title. You have to be a human being, a better human being, and a stronger physician, and someone who really takes care of his patient. Do not forget, our main role is do no harm and treat. It's not making money. It's not being a professor. It's not being the best in my profession. It's not being a media or a social media star. It's treating patients and taking care of patients. That's our primary goal. Money is important, but don't focus on it. Fame might be rewarding to some of you, but do not focus on it. This is not your aim. Never forget why you went into medicine, and never forget that you're treating human beings, patients, fellows, people like you, people who have families, have friends, and have people who love them. So always please keep that in your mind. And never forget, as I've said always, KKESH is not a hospital. KKESH is a culture. So when you go out, spread our culture. Spread how professional we are, how serious we are, and how dedicated and devoted we are. And I wish you all the luck. KKESH will always be your home. Your relationship and your ties to this hospital does not end by the end of the training period. We will always be here to support you. We will always be here to encourage you, and we will always be here to provide any assistance that you might need in the future. And if you feel that you need to come back again, please feel free. You will be welcomed with open arms by all of us. Thank you again, and best of luck.
Thank you, Dr. Rajhi. Would kindly invite Dr. Rajhi and Professor Tabara on stage to present the graduation certificates, as well Dr. Nuwailati to introduce the fellows.
This is the exciting moment. Would like to please ask Dr. Saleh Al-Uthaymin, Chairman of the Comprehensive Care, to come forward and help deliver the certificate of our first graduated fellow from the Comprehensive Service, Dr. Hussein Fadel Haboubi. Next is cornea, external disease and refractive surgery. I would like to ask my colleague, Dr. Samar Swelem, Chairman of the service, to come to the podium. And the first graduating fellow is Dr. Turki Abdulaziz bin Dakhil. We are also delivering an appreciation letter, as he has been the coordinator for the anterior segment service. Congratulations. I'd like to call on Dr. Wala Abdullah Deri. Congratulations. Perfect. Dr. Lujain Talat Idris. Congratulations. Dr. Zuhair Ahmed Mir Alam. Congratulations, Dr. Zuhair. Next is Dr. Abdullah Muhammad Al-Usaili, but unfortunately he's not here today, so Dr. bin Dakhil will receive the certificate on his behalf. Thank you, Dr. bin Dakhil. Also, Dr. Saoud Abdulaziz Al-Sultan is graduating, but Dr. bin Dakhil is also receiving his certificates, 3 certificates. Lucky man. Thank you, Dr. Swelem. I would like to call Dr. Osama Al-Sheikh, Chairman of the Oculoplastics Division, to come to the stage, please. He will give the certificates to the Oculoplastics and Orbit Fellow. First is Dr. Manar Khalid Al-Wahib. There's also an appreciation letter, as she has been the coordinator for the Oculoplastics and Orbit Division. Congratulations, Doctor. Great. Dr. Dalal Ibrahim Al-Isa. Where's Dalal? Here she is. Congratulations, Dr. Dalal. Dr. Fatma Abbas Al-Hamad. Congratulations, doctor. Great job. And Dr. Sultan Abdulaziz Al Hassan. Mabruk, doctor. Thank you, and thank you, Dr. Osama. I would like to call now Dr. Muhammad Al-Shamrani, Chairman of the Pediatric Ophthalmology Division, to come forward, please, and help deliver the certificates to the Pediatric Ophthalmology Fellows. We'll starting with Dr. Maytham Mahmoud Al-Ali. There's also an appreciation letter, as he has been the coordinator for the Pediatric Ophthalmology Division, but we will request, please, Dr. Shahrani to come and receive the certificates on his behalf since he is on leave. Dr. Shahrani, are you around, please? Thank you. And while she's at it, Dr. Shahrani will also receive her own certificate. She's graduating today. Najah, Dr. Najah Abeid Shahrani. مبروك دكتورة. دكتورة فوزية محمد الحيمي. Congratulations, doctor. Thank you very much, and thank you, Dr. Shamrani. Next, we'll ask Dr. Marco Mura, Chairman of the Retina Division, to please come to the stage. And he will deliver the certificates to the Vitreoretinal Disease and Surgery Fellows, as well as the Medical Retina Fellows. We will start with Dr. Abdurrahman Hamad Al-Saidi. Dr. Al-Saidi has been the coordinator for the Retina Division, and there's also a letter of appreciation and very, very heartfelt congratulations from my part as well. Thank you. Dr. Omar Abdussalam Al-Abdussalam. Congratulations, Dr. Omar. Nice. Dr. Abdurrahman Zahir Al-Barqi. Mabruk, Dr. Al-Barqi. Dr. Yahya Ahmed Al-Kreiri is graduating today, but unfortunately he cannot attend today. He's on leave, so we will ask Dr. Ortabi, his friend, to please come and take the certificate on his behalf. Thank you. And finally, last but not least, Dr. Faisal Abdullah Al-Marik. Congratulations, Dr. Faisal. So happy to see you this day. Perfect. We'll ask Dr. Mura to stay on stage because we have our cherished medical retina and uveitis fellows next. Dr. Lama Fawzi Al-Ainani. Congratulations, Dr. Lama. And Dr. Doha Muhammad Al-Hamad, who is on leave, and therefore Dr. Saidi, we ask him to come to the stage and please, yes. Oh, okay. The girls' team, yeah. Thank you very much. Thank you, Dr. Mura. Thank you. I would like to ask the Dr. Ahud Aweda, Chairman of the Glaucoma Division, to please come to the stage. And we will start with Dr. Saad Abdurrahman Al-Amri. who is also the coordinator for the glaucoma division, and there's an appreciation letter for him. Mabruk, doctor. دكتورة ثريا صالح الدوسري. مبروك دكتور. دكتورة أميرة جعفر آل داوود. And last but not least, our very own Dr. Ala Hisham Al-Mufti, who is the Chief Fellow, and we thank him tremendously for what he has done for all the fellows, his colleagues, and the department. Thank you very much, and heartiest congratulations to you, Dr. Ala Hisham Al-Mufti. We still have Finally, I would like to ask Dr. Hassan Adibi, Chairman of the Uveitis Service, to come to the stage and honor the fellows who have also completed a one-year uveitis training. We'll start with Dr. Lujain Talat Idris. Takes really a lot of hard work to do a fellowship and an additional training on the side, so congratulations to all of you. Dr. Hussein Al-Haboubi, again. Dr. Fatma Al-Hammad. Congratulations, Doctor. Dr. Fuzia Al-Hami. And finally, Dr. Yahya Al-Kareri, who again is not here today, and Dr. Atabi will come again to the stage, and this time maybe take a photo. Thank you, Dr. Dibi. Congratulations to all our graduates, and congratulations to the parents, to the families, to the spouses, and thank you very much for joining us in this memorable occasion. We would like to invite the new graduates and the division chiefs, please, on stage for a group photo.
Just a second.
Group photo.
لحظة بس. أنا يمكن فاتني في الكلمة حقتي. أحب أشكر الأمهات والآباء اللي موجودين منهم واللي غايبين، والأزواج والزوجات يلي موجودين، لأنه أعتقد بدون دعمكم أنتم ما كانوا زملائنا ولا زميلاتنا قدروا يمشون بالترتيب، فشكرا لكم.
I will do the picture. Group picture, please, for all the graduating fellows and the division chiefs. Dr. Abdulaziz, we'll do one for the, and maybe with the mothers and the dads as well. Yeah, and لو سمحتوا أهالي الفلوز، أهالي الزملاء المتخرجين، نكون سعداء بتشريفكم معنا للصورة جماعية.